Thank you. So it's a pleasure to be here. It's going to be hard to beat Luke with his talk. He's so passionate and so good. Thank you to bioMérieux to have the opportunity to be here. So I'm going to talk about some specific cases of the STRIDE, which is a wonderful approach. It's a different way of looking, of course, at diagnostic. And these are my disclosures. I get honorarium and research grants, etc., from these companies. And this talk, of course, is by bioMérieux. So I'm going to talk about surveillance quickly, diversity, transmission, and enablement. So surveillance, I'm going to emphasize the role of diagnostic in generating data. And I'm going to focus on gram-negative, which is our main concern, at least in Latin America and Colombia. Help feeding national or global antimicrobial resistance systems, and of course track resistance using real-time diagnostic information. So that's why it's so important. The second one would be diversity that Luke mentioned. It's through HUNET, that's what we use, the platform that we use, which is free, and all the microbiology gets all the data from the cultures, and by back we get this information that I'm going to show you. So it will show you the organisms by different areas of the hospital, and the most common bacteria and the phenotype that they have, and that will help me create guidelines, for example, for that hospital. So advanced diagnostic platforms with multiplex capabilities can identify a wide range of pathogens and resistant markers. That is very important for us to know what to do. Facilitate tailored treatment, because you go to a narrow spectrum or to a broader spectrum, of course, and it will help me be more effective with my treatment. Transmission, of course, will show how rapid pathogens identification supports early containment of multi-drug resistant organisms, prevent cross-transmission in the hospitals, and of course enable infection control. As soon as you have this rapid diagnostic test show you that it's a carbapenemase immediately. You don't have to wait for the culture. Immediately you start with contact precautions. And enablement, a few words about the role of the microbiology lab. So I will start with surveillance value. So this is a study that you may know about. It's a huge study that shows about the burden of antimicrobial resistance in 2019, which reports of death and disability or disability adjusted life years. And the data was obtained from 471 million individual records, 23 pathogens, 88 combination of pathogens and drugs, and 204 countries and territories. So the findings was around 5 million deaths associated with antimicrobial resistance. And what it was very interesting is that lower respiratory tract infections are the #1, of course, of deaths associated with antimicrobial resistance. So we have to focus a lot in our hospitals about these lower respiratory tract infections. So which were the top 6 pathogens responsible? And you will see it that's everywhere the same, but it changed, of course, which is the #1 and the #2. So it was E. coli, Staph aureus, Klebpneumo, Strep pneumo, Acinetobacter baumannii, and Pseudomonas aeruginosa. And you will see this slide, which is amazing, and I'm showing you Latin America, where of course you can see that the bugs are almost the same, but the order is different according to the different regions. So that's really important to take into mind. And there are other surveillance programs like ATLAS, for example, which is the Pfizer ATLAS, antimicrobial testing leadership and surveillance program that gets its data from testing hospital patients worldwide, becoming real-time antimicrobial resistant data. So it's really important. It's more than 200 institutions across 80 countries to gather bacterial isolates from hospitalized patients, which is a different perspective. So it becomes a great example of how local diagnostic test data fits into a large population level initiative. So this is data from Atlas. I took actually, look at Latin America. It's worrisome, look at that. If we look at what carbapenem resistant Enterobacterales are, we are the #1. And what is shown in this graph is also hospitalized, of course, mainly patients that are very sick and probably will get really a bad disease from a very resistant bacteria. So coming back to the Atlas, what are we expecting from these carbapenem resistant Enterobacterales? And if you can see Latin America, is mainly KPC and NDM, the ones that predominate. So that means we have less antibiotics to give to the patients. We're going to be in front of a patient that has a core resistance, as I'm going to show you what happened in Colombia after the pandemic. So we have to report all the carbapenem-resistant Enterobacterales to the National Institute of Health, and they do the genetics of that, of course. And we know more or less what's going on in the country. Of course, the bias is all the Enterobacterales that are carbapenem resistant. It's not all our Enterobacterales. But look at that. Almost all the country reports to the National Institute of Health. And of course, Klebsiella is our number one. And when we have Klebsiella, we know we're in deep trouble. Something is going wrong, because Klebsiella is the bacteria that has the greater capacity of bringing those plasmids inside and reproduce that information. So look at this. After the pandemic, we just saw a huge increase of core resistance that we never had before. KPC was the number one carbapenemase, as is described in the rest of the world, but now we have NDM, and the core resistance is around 50%. So look at this, what happened. We have a clear increase of core resistance. So that makes it even more important to have a rapid diagnostic test, because the phenotype, the culture, the antimicrobial susceptibility will come with everything resistant, but you don't know what's going on, what is happening, and that will help you define your treatment. So what about death? This is a very interesting article, because it shows that death has decreased under 5 years of age. But the group that now is suffering a lot about this antimicrobial resistance is age groups 25 years and older experience an increase in mortality from antimicrobial resistance during the same period, and especially you have to focus on adults that are age 70 years and older. So this is the population that will get a huge impact with antimicrobial resistance. So let's talk about diversity value. So that's what we do with 40 hospitals that we follow in Colombia in 14 different cities. So we get the HUNET, and we do these reports, which are customized report for every hospital every 6 months. So they have the data to build their own antimicrobial guidelines. That's a lot of work, but it's something wonderful, because I have the view of what's going on in the country in the most difficult settings, especially healthcare. So look at how we follow for the whole year. And if you can see here, Klebsiella is the number one, followed by E. coli. But also, we're not only happy knowing this, we need to know the sources. So we look at the sources, and you can say, okay, it's HUNET. It may be colonization or infection. Nobody knows. But look at bloodstream infections. This is infection for sure. And look at this. Klebsiella is our number one bacteria in most of these hospitals. And look at this example. So we have Klebsiella, resistant, of course, to third generation. It could be an ESBL or a carbapenemase. That 40% of our Klebsiellas in blood are carbapenemase producers. Why do I say that? Because in Colombia and Latin America, if you've had an Enterobacteral that is carbapenem resistant, you have 99.9 possibilities that this is a carbapenemase. And then, of course, we look at ceftazidime and avibactam, and we know that 1/3 of those probably are core resistance, and that's why it's not only KPC, it's NDM. Now, look at the other side, emergency room. In the emergency room, we do exactly the same thing, but E. coli is the number one by far. Look at the sources that you're expecting: urine, bloodstream infections. So many of these patients coming to the emergency room may be pyelonephritis also, but Klebsiella is here, so I get a little bit worried about that. So look at the E. coli, 16% maybe of ESBLs, 1% of probably carbapenemase that are mainly NDM, but 1% in such number of cultures is meaningful. And the second one is Klebsiella, and again, 30% of the patients coming to the emergency room that have a bacteremia may have a carbapenemase producing bacteria. So when I use this data, it would be totally different if I'm in the ICU. I would say, as you know, the first bacteria is Klebsiella, 38% of resistance to carbapenem, 33% to ceftazidime and avibactam, KPC and NDM. Second bacteria is Staph, which I know is probably a colonizer. We don't know, depending if the patient has a central venous catheter. The third one is MRSA, which is striking, 52%. So you have to make guidelines, and I have a septic shock in the ICU of this hospital. For sure, I will start with ceftazidime, avibactam plus astronam until I have a rapid diagnostic test that will tell me if that's really what I'm looking at, and this is the resistant pattern that I have. Instead, in the emergency room, you see mainly it's E. coli with around 16% of probably ESBLs, just very low carbaphenemases, so I don't need to cover it in a septic shock initially. So I have to go, if that in the emergency room, I will choose based on the risk factors. So we have risk factors posted in antimicrobial guidelines that all the doctors can access. And depending on the risk factors, usually it's an ESBL, I will start with meropenem, unless it's a septic shock and the patient comes from a hospital that was hospitalized for a long time and I have to cover carbaphenemases. So that helps a lot. So, okay, let's go to transmission value. So this is a clinical case of a patient that was a 46-year-old male living in Bogota with a history of end-stage liver disease, underwent abdominal surgery. On day 4, he developed a fever, hypotension. He was treated empirically with meropenem, which was expected as a combo number 1, meropenem vancomycin, which sometimes doesn't work, of course, and loading dose. And with vancomycin, on day 3, the patient showed no signs of improvement, and severe hypotension was documented, and 2 sets of blood cultures were drawn. So this is the quick result. When you have a blood culture positive, of course, immediately you get a gram stain. If the gram stain shows something, you do a rapid diagnostic test, and in 1 hour, you will have the result. Thanks God for this lucky patient that we have the rapid diagnostic test. It showed that it was a cleft pneumonia with NDM and KPC. So this is the antibiogram. That is very important to do it, but it comes 72 hours after I knew already the results. So with that diagnostic test, what did I do? I stopped linezolid or vancomycin, was stopped. The patient was switched to ceftazidime avibactam plus astronam because he had 2 carbaphenemases. Simultaneously, we still don't have astronam avibactam, it's not available. The infection control team implemented contact precautions immediately. So that was 6 hours after we drew the blood culture, which is amazing, not 72 hours later. And patient, of course, improved in the treatment. So there are many data, not only about mortality also, that you have to take into account, but it really helps a lot. In this case, when they compare rapid diagnostic tests with blood culture results, it reduced median identification time. It decreased length of stay in the ICU. That's a lot of money and a lot of tests that you are saving. Decreased mortality, and the net cost savings to the healthcare system was $11,661 for each patient who had a ICU admission and diagnostic evaluation using rapid diagnostic tests. So you have to go to the administration and say, listen, this is not expensive. It's cost effective for the patient and for the hospital. Okay, going to diagnostic tests and infection control. Diagnostic and rapid identification of pathogens are essential for infection control, as you saw, implementation, which limits the transmission, contact precautions immediately, guide treatment, and monitor disease trends. Also, they are fundamental for tackling antimicrobial resistance, managing outbreaks, of course, and reducing healthcare-associated infections through target intervention, surveillance, and stewardship. And this is a good example in the US, where they mix, of course, the antimicrobial resistance and the infection, the hospital-associated infections. So that would be wonderful to know how much of these antimicrobial resistant bugs are really causing hospital-acquired infections. So this is the map of the countries that report. Unfortunately, not all the countries, and look at Latin America, are able to report that. So moving to enablement value, which is my last, the definition, if you look in the dictionary, in microbiology refers to the critical role, laboratory expertise, automation, and rapid diagnostics plays in optimizing patients' outcome, with reduction in healthcare costs if used correctly, that I'm going to show you in the next slide, as well as allowing faster turnaround times, improving antimicrobial stewardship, and clinical decision-making. So it's absolutely important. So I think this is a very hot and very important topic from that. So you see antimicrobial resistance caused by various sources. So you see that antimicrobial resistance has a high cost, both in health and in the economy. It's estimated that by 2050, antimicrobial resistance could generate additional health care costs of $1 trillion, and losses in the gross domestic product between $1 and $3.5 trillion per year. So as Luke said, it's not only about the patient saving the life. It's about the health system. It's about the country. It's about the nation. It's about the society. It's about many other things that you have to take into account. So I think this approach of STRIDE is a wonderful approach to show everyone that it's not only about the patient. It's about the whole society. Thank you very much.